Good afternoon, everybody. Good evening. Look at that. We already got 9 people on there. This is good. This is good. Give people a chance to join us. It's 5:30. It's first Wednesday of the month. We're here having
Post
Cinco de Mayo.
Siete
de Mayo margaritas. Jason can't do margaritas. He's got a Corona. We're just relaxing. And we wanted to talk with you guys, and we wanted to have a discussion about EDS and hypermobility, because it's one of those things that's out there a lot these days, and it's
I think it's fair to say every one of us have had patients.
Yeah,
It's a lot, several.
I think it's in a good way. I think it's something that's finally being brought to the forefront as something that's out there. So if you're here, comment. Let us know where you're here from. If you got questions anytime during this, just post them in the comments. We'll see them and we can answer your questions. If you got questions on anything EDS related, anything that we're talking about, we'll do it. Anne has kind of been diving into it a little bit more as an interest. So she's done some research and some extra study and education on EDS specifically, but also just general hypermobility disorders, connective tissue disorder stuff. And so she's going to give us some just kind of an overview of kind of what that whole world looks like. And then we'll dive into kind of what we do and how we would kind of get involved in the role that we play. That I think we have a pretty good opportunity to help people in a different way than what's out there. So
yeah, sure.
And I think people always like to know what got you interested in going that direction too. Was it the number of patients you were seeing? Is it
No, so really it ended up, it was last year at the symposium, the PRI first symposium. They had a speaker, Amy Morris. She's a PT out in Pennsylvania. She gave a talk on it and just, I don't know, it's kind of like putting all the puzzle pieces together. Like I like trying to figure out what's really going on. And I feel like this patient population, I mean, Tor and I were talking earlier, I have post-concussion syndrome. Like it's the invisible illness. People look at you and you look fine. Like, so it's all in your head and it about drives me bonkers with that. So, I like having the ability to be able to help them and actually listen and know, like, no, you're not crazy. Like, there are things that we can do. So Amy really spearheaded it. She spoke again this past year, two weeks ago, and dove in even more. Earlier this week, I just interviewed her, diving into more questions. So she is a great resource for all of us. She's helped with some patients here. And she's kind of helping me figure out how to kind of navigate this world a little bit better, and different courses and ideas and what can we do, providers we should try to find to have on our team with it. So that's kind of how I got into it.
And that conversation will go, we'll put it out next week sometime. If they sit down and just a nice conversation on diving in a little bit deeper as to kind of ways that Amy herself works with that population.
Yeah.
It's interesting. The banner for the thing is a big zebra print, right? And I don't know if anybody ever caught that or understands even what that is, but zebras are kind of the hidden message for EDS. And so I don't know if you want to dive into that.
So in medical school, they're taught, you know, when you hear hoofbeats, think horses, not zebras. So
it's probably the most common thing that you would think of. If you hear a horse, if you hear a hoofbeat, what are you going to think? Well, it's probably a horse.
It's a generic thing. So in the EDS world, they're like, oh, it's so rare. You're never going to see this. So these doctors aren't thinking this. It's obviously, as we all know, hypermobility is way more common, but people don't understand it. It's rarely understood.
So doctors are looking for horses, and then you have a zebra sitting in front of them.
And then they're just like, well, who knows? Don't know. Like, you know, go see this provider. Go see this provider. So overall, for people with EDS, it takes at least about 10 years on average to get a diagnosis. I just read a study last night that actually it was 20 plus years for 58% of people to get a diagnosis. So they have been through surgery, medical trauma, social stigma. They've lost their jobs, like all of this type of stuff. So these patients are really struggling to find people to actually listen and then actually help them through this lifelong process. You know, that they're gonna have this for life. So we're never gonna cure somebody. You know, that's a huge thing. It's about learning to help you manage and be able to get back to daily activity. You know, like you're more than likely probably not going to be running marathons, doing all this crazy bodybuilding type stuff just because of your genetics. You know, you might, some people can, like, but a lot of it is, you know, can we get you being able to go to work?
The frustration of people, like, if they've been seeing doctors for 10 years and trying to figure out what's wrong with them and nobody's come up with anything. There's so much medical trauma that's people have been gaslit and just told they don't have anything wrong with them and it's in their head and all this stuff. And then we see them and all of a sudden I think we have some tools that says, hey, actually we understand maybe why you feel the way that you feel, and it can be really empowering for patients just to have somebody to talk to.
Can you talk just for everyone out there the difference between like hypermobility and connective tissue disorder?
Yeah.
So the connective tissue disorder is the big overhauling umbrella. Like osteogenesis imperfecta, Marfan syndrome, EDS. There's two other that I can't remember off the top of my head. They all fall underneath that umbrella of connective tissue disorder. Then each of those categories have subcategories underneath it. So, you know, everything goes back to collagen, it's glue that holds you together. It's in every tissue in your body. So kind of as I was learning, I didn't really know this, you know, EDS has their own classification and it's gone through overhauls. The last one was 2018, maybe. But then there's also hypermobility spectrum disorder. So hypermobility EDS is one of the classifications, but there's a certain amount of criteria for you to meet that classification. There's no blood test for it. There's a lot of research studies in progress trying to find the genetic component of it. But if you don't meet that exact criteria for hypermobile EDS, you fall into hypermobility spectrum disorder. So they know something's going on, but you just don't fall into the classification. So everything that I've been reading is you still treat them the same in a sense. It's just being aware of it. So then them talking to other medical providers like, hey, like I am hypermobile. Like I have issues with skin healing. You know, if they have surgery, you got to think about how they're being sutured up differently, different things like that.
And then I think go ahead.
I was just going to say, I just think it's important for people to understand connective tissue, like Ann said, it affects every cell of your body. Mm-hmm. And it's different than like being like a muscle being stretched out. There's a big difference between a muscle being stretched out
or an ankle sprain
tissue.
Or a whiplash injury or something where there's a trauma to a tissue.
Yes.
And that's why it's hypermobile versus an actual, the way you're built is more loosey-goosey than
connective tissue wraps around your muscle, it wraps around your organs, it's everywhere in your body.
Mm-hmm.
Kind of like what Ann said earlier, it's the glue that holds your body together. So anyway.
I mean, I think personally.
Hey Beth, just so you're there, I got your question. We'll get there.
The other interesting thing that Amy Morris talked about last year and again this year, I'm trying to think of what the third letter of the acronym is, but the mast cell activation syndrome. For those of you who don't know, I think that's a lot of people have inflammation in their body, and it's kind of like what Lori was talking about last couple times about with the perimenopause and menopause stuff, where there's markers in your body. But a mast cell is a cell that starts a histamine that causes an inflammatory or a allergic reaction. So a lot of times you need mast cell inhibitors. So they have an influx of mast cells in their body that cause a histamine that causes inflammation. So like what she was talking about, the glue in your body, a lot of these patients not only have connective tissue dysfunction, but they also have just generalized GI inflammation and food sensitivities and stuff like that. So a lot of times if you start listening to your patients, they kind of put the two and two together. I think that's a big thing because we're always thinking of a joint, we're always thinking of a knee, hip, they're here for
We're
something.
physical, right? So that's
Right.
that's our.
But there's a lot of other things that you got to listen to, and I think maybe when you tie those correlations together, I mean, it's very, and you listen to your patients. A lot of these patients have already been through some of this stuff. I don't know what the treatment is for that per se, as far as how do you inhibit a mast cell. But there's mast cell. I think chromium is one of them. I think it's
I haven't dove into that
I
yet.
think it is. But anyways,
We're working on it.
Done the research on that. But EDS is obviously the kind of the most commonly out there version
Yes.
right now. I mean, that's you hear about it a lot. People say, I think I have EDS, but I mean, Dr. Google told me I have EDS or whatever. Meaning it probably was Dr. Google. But so you made a post last week, and there's right now 13 different types of EDS that have been kind of classified. So now,
How many of those did you see? Because you were talking about a little bit this
Yeah.
morning, staff meeting, but of those 13, there's what, 3?
3 that we will
that you probably
run
into.
into.
Yeah. And
So,
then
so,
there's some
so
are
break down
more-
kind of
Yeah.
just that EDS umbrella, which is one umbrella under
Connective
hypermobility,
tissue.
connective tissue disorder,
Mhm.
which is one kind of hypermobility syndrome.
Yes.
And so there's
Yes.
all these different pots that we put people in. I just
Yeah.
use that word a lot.
Yes.
For
Yes.
lots of reasons.
Yes. So the 3 big ones that we could potentially see that are most common. A, it's the hypermobile EDS. And that's the one there's no genetic testing for it. Overall, from what I've been seeing in different groups, all of this type of stuff it is really hard to get a diagnosis because doctors are not trained how to do actually the testing. They don't want to do it. They don't want to give people labels. And so it's a very confusing, hard world. So either you're hypermobility spectrum disorder or you're hypermobile EDS, depending on the criteria. There's another type called classical EDS. That's 1 out of every 20 to 40,000 people. Is what they're thinking right now. But that one can be confirmed through diagnostic, like blood work. Yep, the genetic testing. So they had different criteria also that they have to meet before they go do like the blood work. So the skin hyperextensibility, so their skin is able to like pull like crazy.
We'll go through some of that stuff.
Atrophic scarring, so they end up with a lot of keloids, all that type of stuff, and then just generalized joint hypermobility. So they had to have all 3 of those major criteria. And then there's also minor criteria that each one of these groups had, like, oh, you have to have like 3 of them or 2 of them. Like, so just some of the other things, easy bruising, soft, doughy skin, skin fragility, if you've had hernias before, umbilical, all that type of stuff, not where it was from like a trauma or it's like, oh, yep, I definitely overlifted like a couch, like that type of stuff. So that's one of them that you could see. The other one that we need to be aware of is the vascular EDS. That has a higher mortality rate, obviously, but it's estimated to be present in 1 to 50 to 200,000 people. So again, it can be diagnosed. Yeah.
What if
Huge
you or what if
ranges
Because they don't really know. They're not really doing
a lot of times they don't know until somebody dies.
Oh,
And then they're like, okay, what caused it? And then they're like, oh, whoa, like here's this. So a lot of this is so underreported. It's crazy. And all the research that I'm reading is like, it's been around forever. I mean, there was 400 BC. There's already stuff written down of talking about people with hypermobility stuff. So it's not something that's
so how did
new.
Ehlers-Danlos? Where does Ehlers-Danlos come in? Is the name of a doctor? How is the name?
That's a great question.
Yes,
Well, I mean, is
and
it after
I
2 people or?
couldn't tell you the exact answer. I remember reading it at one
We'll have to
point,
look
but
that
it's
up. That's a good question. You should look that up.
here you go.
Yeah.
Would you like to look that up right now?
That's one of those things.
Well, let's continue with
Go ahead.
vascular
But-
EDS.
Yeah.
Vascular, it just means that the connective tissue of the actual blood vessels is affected.
Yes.
Which they're going to be more at risk for aneurysms and strokes and
Mhm.
things that are really more dangerous, so to
Yep.
speak, as far as that. And that one has a genetic marker, right? So the
Yes.
classical EDS, there's a genetic marker. Vascular EDS,
Vascular.
there's a genetic marker.
Yep.
And the other big one that we see is that we're going to see is the hypermobile EDS,
Which does not.
which
have
does
a
not
genetic-
have a genetic marker. So that, how do we tease out who should go get tested or not tested, so to speak?
Yeah. And a lot of it's family history. You've talked about your one patient, there's a family history, so okay, she should go get tested. But there's also, when I spoke with Amy Morris, who's kind of the specialist in this world with PRI, there's times where we don't want people to get tested because it can affect your ability to get disability insurance, all these other different things. So you need to be mindful of that and not just be forcing people to, go get the test, go get the diagnosis. There's also a new thing where people can send their send your blood, saliva to a company and get genetic results back, but they're showing that 40% false positive on the test results. So
It's worth it to go see somebody who knows what they're doing.
go see somebody.
I guess the biggest thing is there's a lot of people that think that they're hypermobile. We have all the access to information now. People are questioning their doctors, which is why I think it's out there more now. And so that's the hard part. I didn't realize this until you were telling me that hypermobile EDS, there's not a genetic marker for it. But so you meet the criteria, but they can't figure out where it's coming from. So do you need to go get genetic tested? Do you not need to go get it genetically tested? As far as what we're concerned, we're probably not going to treat you differently in terms of how do you manage it, which is our role, whether you do or whether you don't. The big important one is that vascular EDS that says if you have a family history where you had a dad or an uncle die at a young age of an aneurysm, maybe it would be good to know that that's a thing.
Yeah.
So, but otherwise, for what it's always good to have more information, but you can have hypermobile EDS and still not have a genetic test that's positive. So it's not like we have to rush out and get genetic tests for all our patients. We're trying to figure out, hey, how do we get people in a position where they're doing a better job? So the one, I guess, any comments on some of the other? So like I said, there's 13 types. Those are the three main ones.
Those are the three main ones. The
Talk
other
about
ones,
the other ones that are 'cause they're out
there's-
there, and it's a little bit.
they're out there, but a lot of them, some of them, there's only 6 cases reported. There's fewer than 30 cases. A lot of them are within the same families. So arthrochalasia EDS, 49 patients from 36 families.
So
you
You probably know. You
Kinda
probably
know.
know. So there's a lot.
Right.
It says
Know.
13, but a lot of these are really
Um,
rare.
So you have classical EDS,
mhm.
you have vascular EDS,
And
and you have
hypermobile.
hypermobile
So
EDS.
those are the three
Those
that
are
we're-
the-
kind of
Those are 3
tie back
that you're going to
together.
run. There is
Yeah.
one. Beth asked a question here a little bit ago about is there a connection between EDS and teeth instability,
yes.
Yeah.
or moving in your 40s or eye change in amount of vision. So their corneas and eyes is connective tissue, and all the tissue around the teeth is connective tissue. So if you have a hypermobility issue, you're going to have teeth that move all over the place. And Beth, I know your story. You're probably somewhere on a spectrum. There's actually one type of EDS that's its primary
Specifically
factor is
teeth.
specifically teeth. People, their teeth just fall out because the connective tissue holding the teeth in is too loose. So I don't think that's what you have. Beth, your teeth haven't fallen out, but people who are a little bit more hypermobile, they're going to probably see bigger changes in eye shape as we get older, or cornea shape, or tooth stability. So that makes sense there too.
just to answer that, I had a patient that's hypermobile that went through orthodontia, and I remember Dr. Holt talking about like it was like moving teeth through water.
It was just so easy
Her
to move them.
her teeth moved really easily, but we made modifications for that to give her more stability. But sometimes that's when it's
Yes,
good to know,
similar to
but-
that, I've got a patient who needs a dental appliance. That's the thing that helps her get neutral. But unfortunately, it wreaks havoc on her because of the teeth.
Teeth moving
Yeah,
around.
absolutely.
Around so fast. The MAC, thanks for the question, the MAC. How important is nutrition for hypermobility and advice on what to take nutrition wise? I think that goes up because that was when Jason came through talking about just general information. Usually, if you got hypermobility, there's typically
Food sensitivity.
generally a whole body inflammation, and there's probably some connective tissue of the gut involved.
Yep.
Now you and Amy, I don't know, did you talk much GI
think
issues?
they
That's what you talked about at our
That's what you talked about at our
symposium.
symposium.
But it goes. There's so much GI issues with hyper because it's collagen, it's connective tissue.
Mhm.
So I know that Amy's big
She's big on Whole30.
was Whole30, and that's just a general thing. But it's kind of anti-inflammatory. It's healthy, but nutrition can be a big deal. I know you've been talking with Dr. Elton about nutrition, and it's good if you have issues GI wise. Get with somebody that knows what they're talking about. Get to somebody that can kind of work with you one-on-one to figure out how do we manage what's going on with your GI tract.
And it could be constipation, you guys. It could be irritable bowel. It's not just
Celiacs.
yeah.
Yeah, and that's something
Gastric
she sees so
dumping.
often.
87% of people with hypermobility usually have a gut.
The GI issue, what that goes with. So nutrition is going to be tied in just about all the time is what we're seeing.
I think
Yeah.
And part of that is GI issues. Part of that could be postural related on kind of things that we're talking about that we're going to get into. What are you doing with your pelvis? Thanks, Michelle, for the question. I think you hit it 100%. Michelle Spica said she thinks that as a pelvic PT that hypermobility is vitally underdiagnosed. It's just not out there. And Michelle works with Ep.4 all the time, and she's seeing it all over the place. And these women just aren't, don't know that that's a thing. But Michelle, because she knows some PRI stuff, is very powerful in help those people regulate pressure better. So Michelle, thanks for all the work you do. You're awesome. Great comment. I love it. Other EDS things. I know you had a bunch of stuff you kind of went as far as those 13 types that were there. Not necessarily.
Not necessarily. Just kind of seeing how things go.
Paigu, next question. Do you find that hypermobile folks need more GRF input rather than less due to impaired stretch reflexes, particularly early heel strike and eversion, ground reaction force input? So we're going to get to ground forces, Pi. I think that making sure these folks are grounded is a huge issue. I don't know if it's ground reaction force input, but definitely feeling grounded. One of the I think that the first thing that I know you look at, the first thing I look at with somebody that's got hypermobility is they have to figure out where the ground is. And I think that's such an undervalued part of treatment with these folks that they just need to know ground based. And I know you can maybe speak about shoes or just orthotics in general, because you're gonna have hypermobility of a
ground
foot.
sense. Yep, and and part of that.
So GRF, ground reaction forces thing,
heel
just
strike,
general ground sense.
Yes, absolutely. I mean, ground sense is huge. If you don't have the ground, I think in some ways you could say we're all unstable.
So if you're a little unstable to begin with, then
exactly. Then this
more
compounds the whole issue. So absolutely.
Your brain's ability, you guys, to feel the ground underneath your foot helps you to regulate internal pressure.
Yep.
And so if you can't sense the ground, your body will compensate and adapt, or it feels like it's on a cloud. So it may actually create more neurological tension and make it hard.
Mm-hmm.
I mean, your brain will feel more unstable. And if your brain feels more unstable and already you're an unstable individual with connective tissue disorder, that can actually create more neurological tension.
Mm-hmm.
And, I have a patient that is hypermobile and unstable, but she has so much neurological tension. You would think she's hypermobile because yet she is so tight.
The pressure,
Because of the
her
neurological
pressure
tension.
regulation
Her
is
brain
off.
to help
Yep.
get that stability.
Yeah, and there's a significant difference between neurological tension
Right.
Mm-hmm.
and hypermobility of an actual connective tissue. And so if you went to just a general practitioner and said, man, I feel really tight. I have this tension in my hamstrings, I have this tension in my neck and my back. I know the patient you're thinking of. What traditionally the treatment is what? Stretch it, right?
Right.
That's what we learn in PT school, right? If it's tight, stretch it. And for somebody who's hypermobile and already has collagen that's to lose, that's probably one of the last things you actually want to do is to stretch, even though they have tension, right? So there's a difference between neurological tension and actual tightness.
Yeah, they're bracing,
Yeah.
which you don't want to be doing a Valsalva. You don't want to be bracing. You don't want to be forcing to try and manage when you're
So the hard thing is when you're hypermobile, what do you like to do?
right.
Stretch.
Right.
Because you can, right? It's one of those things you're actually kind of good at, right? From a little kid, you were told.
And it feels good at the time.
So it's a hard thing for somebody that's hypermobile to say, hey, we don't really actually want you to stretch. We know you have tension, but the reason you have tension is because of these forces, this ground reaction forces, this ability to sense where you're at. That's so different. So ground force is definitely one of our first thought processes, and then that's necessary for what Lori said, which was internal pressure management, which is what Michelle's talking about from the pelvis perspective. So once we have ground forces, I don't know, Jason, the thought you thought was, where do you go after first when you have somebody that's hypermobile as far as helping them feel pressurized?
Well, you got to get them to breathe, and you got to get them to feel the
So
floor.
breathing is the first thing next thing you're gonna go after, right? So I don't know, what do you think about breath work with your ADS patients?
I think it's huge. I think a lot of them are hyperinflated, or they don't know. I mean, they got a lot of brain fog, or they just don't breathe, so they're not getting proper oxygenation through their body, which also causes increased inflammation.
And all the same
all
things
sort of
that we're
stuff. So it's
talking
all
about.
kind of, if you're not getting the oxygen to your body and you're in a bad posture position, it's all going to be interrelated. So they're all kind of
So hyperinflated. When we say hyperinflated or hyper. I guess it would be,
So-
what would you? How would you kind of describe that to?
so hyperinflated people.
Because that's how these patients live is hyper.
So their ribs are up. So when you take a breath in, your ribs come up. As you exhale, your ribs should go down. But if their ribs are stuck in a elevated state, they can only get so much air into their lungs because they can't get the bad air out of their system because they got too much air in their lungs. So they got too much air in their lungs, and they can't get the air that the carbon dioxide and all that other stuff out of their system.
So they're actually using that air for stability. They're holding their
Yes.
breath for the stability they don't inherently own.
Yep.
Right. So we see that rib-wise, breathing-wise, and then what does that do to the pelvis?
They can't descend.
Right.
Yep.
So now we got pelvic floor dysfunction, Michelle's seeing, and then
That
You all-
pushes down on your pelvic floor.
and so they show up with what Michelle says,
Prolapse.
prolapse and pelvic
Because of
floor
pressure.
pressure. And so just to do pelvis issues, and you haven't gotten them to breathe well or get ribs in a position, but that they also have to have ground reaction forces in order to feel that. I mean, that's such
Well,
a
and
huge thing.
One thing, just all of that we're talking about, like I didn't realize that patients who have EDS hypermobility, like literally their brain, their spinal cord, their dura is different. Structurally, it is different. So these people, their fight or flight response gets triggered way quicker than somebody who doesn't have it. And that's why, we have to go slow. I mean, I feel like for PRI, like, yes, we don't give 10 exercises out. We're slower than traditional PT. But these patients need to feel safe. Like they don't know, they don't have a home in their own body. They're lost. So all of these things, you have to address it, but it's more education, giving them, when I talked to Amy, she's like, her number one thing is educating your patient more than you even realize. So let's say they're like, oh, I'm going to go on a cruise, or I feel good enough to go on vacation, I'm going to do this. She goes, all right, well, if you eat this, like, or you indulge for a night, you go off to college, and, you're hanging out, all this type of stuff, get ready, you are probably going to have a flare up, and so then when her patients come back, she's like, well, remember, we talked about it. So it's not like a freak out mode.
Mm-hmm.
Oh yeah.
What
It's
would
already
you call
there.
like a flare up for someone with hypermobility?
Yeah.
So
You just had one yesterday. I mean,
yeah.
not you personally, but
yes,
but
yes.
a conversation. But it's a great question. question.
You know, so my patient has been doing pretty darn good, you know, like not having the dizziness, the lightheadedness, starting to feel stable. She is getting to, 3 out of 5 lift scores. We finally got her up on her feet really well. And school, life, whatever. I mean, she texts me, she's emailing me in tears. She is in so much pain, can't lift her arm up, can't hold anything in her hand, to the point that she ended up going to the ER and got a shot of
So
pain
again,
meds.
normal stress, right?
Mm-hmm.
Normal life was exacerbated. So now we have a flare up and it's pain, it's
Mhm.
whatever symptoms they have. Or
Hot
they-
symptoms.
hot
Yep,
symptoms.
just thought
That's
GI
not
it.
really
issues are probably going to be
GI
working a lot.
issues.
Yeah, a lot more
Yep,
sensitivity.
all of that type of
So if
stuff.
you go to your GI doc and say, I don't know what's going on, my guts hurts, and they're not going to be able to kind of put those two pictures together with, hey, this is just part of this whole system that we're looking at. So your patient had this, unfortunately went to the ER. Not unfortunately.
Well,
went to the ER.
that was probably a good
Unfortunately,
thing because it
Calmed
helped
her down.
calm the system down, trying to find a different pain med doc so we can just have some kind of long-term management because the primary doctor doesn't want to do it. And the first place that got referred, they laughed at her when she asked, do any of your providers know anything about EDS and that type of stuff? And laughed at her on the phone, said nobody in the state of Nebraska knows it and good luck. And then refused to ask any other questions. So we are working on
So we're
trying to
so we're
find a
we're
new
still in that mode even here. That's
of trying to find providers who will actually listen and she doesn't want to be on pain meds, all this type of stuff. But every now and then when there's these massive flare-ups, there's not much that you can do, so it's managing it.
yeah.
So
By a flare, it could be a flare for you and I. We lifted
Shoe question.
and we got shoulder sores. They're going to be on better. Steve, thanks for the shoe questions. Good replacement for Brooks diet. There's no good replacement for the Brooks diet. The Mac, does hypermobility get worse or better as you get older, even though doing PRI, even through doing PRI as a young adult?
I think the thing there is you're not. It's.
You're
I don't know that it's going to
Yeah.
necessarily get better or worse, but I think the value of PRI is we're putting you in a better position to function where you're not trying to function in a compensatory way, where you're not trying to make a ligament, a joint do something it shouldn't be doing from a bad position. So I don't know that you're going to see it necessarily get better or worse. I don't know the answer to that, but I think where
Well-
PRI comes into play
So
is
yeah,
you
but
function from a better
Yeah,
position.
the hypermobility, your genetics are going to be the same.
Right.
We're not affecting your
Teaching
genetics.
you how to manage.
I think
But-
as you
but as you age,
your tissue
I
becomes
mean,
more.
you even go
lax.
into the perimenopause, all the changes that can happen just for women as we go through that.
Aging
Like
process.
it's the aging process.
Right.
So sure, maybe it does flare up
Right.
because women don't have estrogen as much. All of that type of stuff.
Well, the
So
integrity
you
of the
can't.
tissues aren't the same.
Right.
I don't know if I'd say better or worse. I think things can just change through life,
Correct.
and it's learning how to manage it.
Right.
So it's not going to be like, ooh, it's a one and done. Ooh, we're good.
Right.
We're
It's a lifelong adventure.
probably going to be on the journey together, but hopefully not having to see people all the time. It might
Right.
be, oh, let's just do a check-in.
So in general, let's say you, Jason, you meet somebody at your kids' your kids' volleyball game, and they say, hey, and their daughter's got joints that are their elbows are lax, and they say, hey, I think there's something weird with my elbow. Like, what would be your just general recommendations, particularly just from like you say, how do I manage this kind of long term? Do you have ideas of what you would just not like coming to see me for PT, but what would you say would be important things for just anybody out there, even if you're not on EDS spectrum, you just say, man, I think I'm a little hypermobile. Do you have ideas for just?
I think the big thing is stretching. We kind of hit on that earlier. I mean, it's stretching is kind of taught at an early age from PE class to where we got to stretch. I think the debate's still out on that. I mean, you really wouldn't want to stretch
Right.
a whole lot. What are you going to do to start stabilizing things or start asking if they've had any?
So you would say more strengthening rather than strengthening.
Stretching.
Strengthening rather than stretching.
Yes, stretching.
Is that what I said? margarita.
But how are you gonna start to stabilize joints, or how are you gonna keep them from being more hypermobile?
I think some of that is that education, depending on the activities, you kind of brought up the idea of when you have one of your kids' events, if it's a dance thing, dance is so focused on what we would call is too much flexibility. You think that being able to stand and palm the floor is a good thing.
Because they're good at it,
Right.
right? So you're
Yes.
going to see that in that population. That's kind of why it was
Right.
Yeah,
And, those people that think that
yeah,
a straight leg raise where you get your knee to your nose is a good thing, and in our world, that is not a good thing.
You're going to want to dance. So what advice maybe would you give them to say, hey, here's the things I want you to do?
Oh, you're asking.
Anybody,
Yeah.
right?
I think it comes down to, I think you got to at some point in time get your hands on the patients and look at them and test them and try to be able to walk through and explain why, if you can touch your nose to your knee, why that's a bad thing, why that is more of an instability than a good thing. A lot of times I've used the example of a pedestrian bridge. If you've ever walked on a bridge that's intended for people to walk on, if you've got hundreds of people walking on it, that bridge is intended to have a little give. You'll feel this little poof. If there's too much give, that's instability. It's going to fall apart with all the people on it. Too rigid isn't good either, but that's not really what we're talking about here. It's really finding that balance where there's some give without being too much give.
But what I tell my patients on that note is sometimes, like, if you have them, we'll have people shipped to no left hip in a PRI world.
Right.
I have to tell they get a different proprioceptive sense from their body because of their
Right.
hypermobility.
They don't
So I have
they're
to
in
tell
their head,
them,
but they don't know they're in their
Give
head.
me 50% effort.
Mm-hmm.
And so because I'm hypermobile and gymnast and dancer, and so we tend to want to lock out our joints. So,
Mhm.
I can go all the way here, but I have more than 0 degrees of elbow.
We're getting there, yeah.
So, work through like 80% or 50% of that motion, and then educating them to make sure that they can turn on a right muscle, so you know that they're getting stability through a muscle versus stability through a soft
Yeah.
tissue. People will tend to breath hold. They tend to clench. I have a lot of butt clenchers. I have a lot of breath holders, a lot of toe clenchers, hand clenchers. People will clench with their teeth. They'll gain it from any other place to gain stability. So sometimes, like we've talked about, some of these patients need a splint in their mouth to help out with that, to help them to get a different proprioceptive sense versus, overcompensating through their bite. But I'm talking.
So, and similar to that as well as the people you talk about that elbows don't go too far, is it the people that stand and they're hyperextended and they don't even use their muscles to hold them up. They stand and they lock those knees back and they're literally resting on the end.
We were just talking about a long time.
Yeah.
Right.
So
It's hard.
yeah.
Michelle, you know the patient, but some of these people, you do everything you know how to do, and sometimes it's hard. They're hard. Sometimes you can overmanage them too. And they're, you know what I mean? It just sometimes having them go out, and it's okay if you just go out and go for a walk. You may not be able to lift weights or maybe do that aerobics video that you want to do, and helping them to find things that they can be successful at and not overmanage. But
So yeah.
I will, Michelle, when you talked about, getting a diagnosis or not, I do agree with you. But it's sometimes some people get so many labels. I kind of go back. Yes, you have hypermobility, but sometimes I don't like to over perseverate on it. And maybe that's not good all the time, but they get so many labels or so many diagnoses.
Well,
It's like
I think it's good for some people. It gives them a
I
mental
think
mind
yes.
frame
Yeah.
of it. But like I listened to a commercial years ago. I was on the radio, and I think it was a cancer commercial, and they said, "You have no control over a diagnosis. If you have cancer, you have EDS, you have whatever it may be, diabetes. Okay, you have no control over it, but you do have control of how you manage and treat it. You don't have to go through chemo. You don't have to go through radiation.
Yeah.
So it all goes back to how you manage it or how do you treat it. You
Yeah.
don't have, once you have a diagnosis, you have a diagnosis. You're labeled with that. That you have no control over that. You are labeled.
So for some, I think it's
Some people it's good.
patient. Yeah, it's they want
Peace of mind.
it helps them kind of feel like, hey, somebody understands
There is
me.
something
I have
wrong.
something, but
Yes.
don't stop at the label,
Yes.
right? And some people don't want the label, and they just want management.
Yes.
So that's kind of just depends. I think you have to feel out what
Yeah.
the patient needs.
Who knows? And I think the big thing, a lot of times the patients that we see here, all of you guys have heard it. It's, oh my gosh, you actually just listened to me.
Mhm.
Like, you're not crazy. Like, and all these specialists, all the doctors they're going to, they're looking at one little area. Whoop, doesn't
Two
show up on
specialties.
an MRI, a blood test, whatever. Well, I don't know. Like,
Well, that's the key word right there. I don't know,
yeah.
and it kind of
It's
stops.
called idiopathic.
Right.
That's
Yeah.
what that means. I
Right.
think what you said to me earlier about what Ron told you when you came dealing with your
Yeah.
issues concussion wise, that was, I mean, of all the things Ron says, and if you've met Ron, he talks a lot. But the one thing that he said that struck with you was,
First time I came here, I had a 2-hour appointment with him. And he said, nothing you can say is like crazy enough out there. Like,
he's going to make me think that
it's-
you're crazy.
yeah. Like, he was just like, tell me
And so-
anything, everything that you are feeling, experiencing. It's all a piece of the puzzle. And it is part of what we got to use to help figure you out how to get better.
And so for somebody, so I think we all do that with patients. They just tell me you're like,
Mhm.
whatever's going on, we're gonna put that in your puzzle. It's nothing you can say is gonna make us think you're crazy.
And don't you guys find that a lot of people that are hypermobile, because of the hypermobility, they tend to have a lot of dysautonomia or pause?
Absolutely.
And
100%, which is
Yeah.
another one of those hidden diseases that now all
Right.
of a sudden it's just in your head.
And that's why sometimes you guys, a splint, it's not about your body, it's more about the neck, controlling the neck
Yeah.
position because of the hypermobility back of the neck. And if that splint can help the neck to have a curve in the neck, to help the neck to be stable, it can help take stress off of a vagal nerve that goes back, or your brain stem. And that vagal nerve or that brain stem can control heart rate, blood pressure, dizziness, lightheadedness, breathing. And that for me as a clinician is hard to manage.
Yeah. So
Mhm.
whether that's traumatic,
Yeah.
OA hypermobility, that's whiplash,
Yeah,
or it's
or
EDS hypermobility, that becomes really challenging for the patient and for us as well. Michelle's question about her patients like getting a diagnosis. There are things that as PTs that we can help our patients, like, hey, you do fit in this kind of category. It's called the Beighton Scale. And I know you kind of wanted to maybe go over the Beighton Scale a little bit. And so Michelle, as a practitioner, there's some things that we can kind of do to help educate our patients that, hey, you fit in this category. Maybe you should go get tested. Maybe you shouldn't go get tested. And so I don't know if you wanted to maybe touch on the Beighton Scale a little bit.
Yeah, well, so for people to get the diagnosis of the hypermobile EDS, there's 3 different criteria that they have to meet. Number 1, the biggest thing that I can recommend is the Ehlers-Danlos Society. They have a webpage. They also have an app that is amazing for patients, for providers. But let's say you have somebody that you think, might have hypermobility EDS. There's a diagnostic tool. Okay, you can go in here, and then you can pick. There's what age is the person, because it changes as people get older a little bit. So you can go through, and it will literally take you through the Beighton Scale and how to score it. It gives you videos of what it is, and you can go through it. So the first one is with your wrist flat on the table. Okay,
I just put it up here on the screen there. So
pull your pinky back.
there's 3.
to 90
It's a
degrees.
9-point test, right? And so we can kind of go through this,
Yes.
right? So this is the
Yes.
first part of the scale. So you put your palm flat on a surface, right? And then can you pick your pinky up to 90 degrees or more,
Mhm.
right? So if you can get your pinky past, so 90 degrees would be straight up and down. So if you can get your pinky past 90 degrees, you get a point, right? I don't know if you want points on
I'm
this.
at like
on this
10.
scale.
Yep.
I'm at like
I am.
40,
Am I 90 degrees?
85. I'll give you 85.
Yeah, you're not quite 90. You and me are pretty close, not quite 90, but
Yeah.
So it would be you have to get past 90 to get a point.
Okay.
And you get 1 point for each finger.
Okay.
Right. So that's number one. That's on the screen here. Number two.
Number 2, can you take your thumb to
Elbow straight.
arm out straight, palm facing down, wrist fully bent downward. Can the thumb be pushed back to touch the forearm?
Oh, good. I thought I can't do
Yeah.
that.
Okay,
So that was
same
1
thing.
point. 1 point
You're
for
fairly
each.
hypermobile.
Yeah.
Yeah.
I mean-
but I can't get there. But I'm
No,
yeah.
but I mean,
But I-
even
I
watching you
get
pull
there,
your
yeah.
finger back, I was shocked.
I tell people hypermobility. That was a pretty good one actually. Jason's probably the best one.
Oh, yeah.
He's within an inch. Right, and so it's a spectrum, right? Some people are more plastic, some
Right.
people are more elastic.
Number 3, with arms outstretched and palms face upwards, does the elbow extend more than 10 degrees?
So that's where Lori gets points.
Lori gets a yes.
Past 10 degrees, so 0 would be straight. 10 degrees past that, and we can measure it. Michelle, you can measure it if you really wanted to. So Lori gets 2 points, 1 for each elbow.
The next one is standing. With knees locked, does the lower part of the knee extend more than 10 degrees?
So more than 10 degrees of knee bend backwards. When you
We
stand.
know Lori has it, so we're
And we see that with a lot of patients, and our EDS patients live there because that's where they feel the
That's
most
where
safe.
they, right?
So, but unfortunately, it creates more instability because they live there, and so it's not a good. So you see people that lock their knees out. That's kind of a classic.
Mhm.
like, something's going on.
Maybe you should be able to do that. Could do. So you get 1 point for each knee if you can go past 9 degrees.
And then the next one is, can they bend forward and place the palms of their hands flat on the floor in front of them without bending their knees?
Which we talked about for a standard reach test, which we did even last week as a standard reach test. But so you there's 9 points, right?
Yep.
Pinkies, thumbs, elbows,
Elbows.
and knees.
Yep.
That's 8,
And then your
and then
ability
on
to
the
touch.
floor.
Mm-hmm.
So that's kind of the
You
first
touch the
thing on there. So that's on the screen.
Barely.
Yeah.
I would call it negative.
So maybe you're at like a 2.
Yeah.
And the rest of us are pretty stiff.
So on this app, it goes through, it scores it for you. And then for the second criteria, you have to have 2 or more of the following features from feature A, feature B, feature C.
Yeah. So Pi's comment was Beighton Scale doesn't account for axial hypermobility.
No.
That's
Which
where
is
you're right.
why,
And it doesn't, right? You're
Yeah.
completely right. But if you have distal hypermobility, you probably also have axial. So it's just saying, is your collagen and your soft tissue limited, right?
Yeah.
Obviously, you're gonna have pinky problems if you can deal with your pinky, but
Yeah.
you're
So
probably
if you have
also gonna have that.
hypermobility in all the other joints, you're probably going to have hypermobility.
But
in
you're
the axial
completely right,
joint.
Pi. That's
Yeah.
Yeah.
the debilitating part is the axial hypermobility. So that just says
Yes.
your general, and that Beighton Scale is just the first stage.
yes.
Right?
And,
So the rest of the
we know the Beighton
the
Scale
criteria.
is not great. In one of the books that I'm reading, there's like an upper limb and a lower limb that's a little more specific for testing for hypermobility. That us as PTs probably could do better than any primary doctor, all of that type of stuff, just with our knowledge and everything. But unfortunately, this is what they have right now for people to use. So you kind of take it as a grain of salt, but I think it's more all of this other criteria for people that they have to meet is really where it's like, okay, like, yes, there's something more going on.
But that'd be a quick screen. Hey,
Right.
you hit 6, 7, 8 of these criteria. Maybe we should dig a little bit deeper.
Yep.
So that's then you would go into criteria 2 or criteria 3.
Yep.
So I'm gonna put this page is on there. This is what Anne's looking at.
Yeah.
And so it goes deeper into what might be other things that would say, hey, maybe you should go meet with a specialist, and you have some tools now at your disposal as a patient.
Yeah.
And so criterion 2 is because it's too far away from me.
Unusually softer velvety skin, the skin hyperextendability, stretch marks in people that not where they're pregnant or they have like massive weight gain or growth, but just unexplained stretch marks, abdominal hernias, atrophic scarring, prolapse in children.
So things that are kind of unique. So not only hey, are you bendy, but do you
Yeah.
have other
Dental crowding,
systemic things
You know,
that
just
are
different things like that. Feature B is just a positive family history. Does somebody in your family already meet that criteria? Feature C, musculoskeletal pain in 2 or more limbs recurring daily for at least 3 months, chronic widespread pain for 3 months, recurrent joint dislocations, or frank joint instability in the absence of trauma. So
Hey, you have a lot of these guys. Now criteria 3 says you have to meet all those. And then we say, hey, now we think you're probably a hypermobile EDS.
mhm.
And if you wanted to go further with genetic testing, you could, especially if you have a family history of
So
that. So that's just kind of the diagnostic part of it, which, okay, that, like Michelle said, that's good for some people to have a good knowledge of it. It doesn't necessarily change what we're doing as a treatment when those people show up at our office, and they show up all the time.
So just to kind of like summarize for people out there,
Mhm.
for like
You do a
what
great
we
job.
do in the clinic to help people with hypermobility, we talked about grounding.
Mhm.
We talked about breathing. We talked about good footwear.
Yeah, which
Yeah.
is shoes, orthotics if you need orthotics, especially with hypermobile activity. So our top 5 tips, you're hitting them, right?
Mhm.
Get good shoes, get grounded, learn how to breathe well,
And then we talked about a
Nutrition.
splint.
control inflammation. We didn't get explain
Yeah,
a little bit, but
control inflammation.
control inflammation. We talked about that. Splint is such that dental part of things in the neck
And
is
that
such a
can vary.
huge thing.
Mhm.
Such
Yep.
a thing. So that's one way we help manage that base of that skull, which is so hypermobile, and we'll dig into that probably next month a little bit more. But that's
And
a big
then-
thing.
Exercise.
And then we're working
Progressing
slowly with activities that are designed to help with joint, not protection, because they just don't move your joints, but how do we put your joint in a good position to where you're not putting excessive strain on it in a bad
Right.
way, which we do with all our patients, right? Somebody comes in with trochanteric bursitis, we know that they're putting excessive strain on the hip they shouldn't be putting on the hip because of the position the hip is in. Our EDS patients, they're not going to probably get the bursitis. They're just going to pop their hip out and just have
Right.
pain, right? Or they're going to have pelvic floor issues. They're going to have other things. But it's the same. That's what PRI teaches for everybody. It's not one joint at a time. It's a whole body approach to how do we manage that patient.
Some other things that I have found, and I know I've shared it with you guys, is KT tape
So-
has
so-
been really
Which gets to
beneficial.
Elisa's
So
question.
Elisa's
Says
question.
patients with EDS benefit from increased external references
So external
and
references.
light external resistance, which
Yeah.
is we talked about that this morning. So Lisa, that's a perfect comment. So dig into that a little bit because I know you had some
When one of my patients is hypermobile, putting KT tape behind her knee joint so she can't hyperextend her knee.
So she can feel when she does hyperextend.
Yeah.
She doesn't even know she
Yeah.
hyperextends.
Right.
I
It's
mean,
just
that's
so
her
That's
normal.
who she is, that's her
Yeah.
normal.
Has been a game changer. Sometimes, even a little abdominal corset to help out with breathing, or using KT tape on the ribs, or
It's been helpful.
so.
Compression
it's
garments.
Compression
it
garments.
is such for me. It's like you're a gourmet chef, because what works for one person of hypermobility can be completely different from someone else, and sometimes it's easy to manage, and sometimes it's,
Mhm.
And that's why it's a spectrum.
Yeah,
You
it
know,
is.
you can have the
Yeah.
same
Right.
diagnosis of hypermobile EDS and you present totally different ways, you
Yeah.
know, and so you can't do this work for one person, like it might not work for the next. So it's kind of
So that's the part that's kind of fun. But at the same time, with what we do PRI wise, we have a framework that we build off that says, here's our goal of where we're aiming for.
Yeah.
And we have some objectivity that doesn't always hold true with our EDS patient, but we at least have an understanding of where we're going. And we can put those puzzle pieces together of how this is affecting that and those sorts of things. So I think it's just reassuring for patients to know that somebody actually doesn't think that they're crazy and just
And just trying to find people in the medical community, even like reaching out to gastroenterologists here in town, and none of them work with hypermobility. And no one at UNMC, and they tell you they need to go to Mayo Clinic because they need more tertiary care. And so it's not, I don't know if it's well understood or well
it's
comfort
not well
level
understood.
with how to treat it. It's
Well,
hard.
my question was if you think you have a hypermobility issue, would you go to your GP? Would you go to a rheumatologist? Would you go to an
Who would you-
orthopedist?
who would you help?
Who does the EDS people recommend to get the, or is
Yeah,
there?
and that's why
very
they have
hard.
10 different doctors
Well,
before
yeah.
somebody finally says, well, I think I have an
And-
idea of how
Who would
to
do the genetic testing?
I would go to a functional medicine person personally. I don't know. what
Yeah,
you say.
no, that was Amy's big thing. A functional medicine doctor is a huge key member of your team. If you're trying to get the diagnosis, like I just saw that UNMC rheumatology was starting to do some of the diagnosis stuff.
that's probably the more systemic kind of minded
They got
rheumatologist.
overwhelmed with the amount of people that were trying to get tested that they are no longer doing it. So it is very, very, very hard. I'm part of the Nebraska EDS Facebook awareness group and that type of stuff. They have a providers list. Most of the providers are not even in Nebraska. If you're trying to get an actual diagnosis, one of the guys, Dr. Saperstein, he was down in Phoenix. I worked with him when I was in Phoenix. Does not take insurance. It is at least 6 months to a year waiting list. Because he asked to get all of your medical records sent. And he literally goes through everything before he even sees
And
you.
usually then you've got
The history.
Yeah, you got a massive history, so it's
frustrating, but at the
it's
same
super
time,
frustrating. But people want the validation. But if they're just hypermobile EDS,
if you can find somebody that
There's-
can at least start to get you in a process to feeling better. No, so I think
Yeah.
just to rein it in, I think what I like about it is that I think we can impact these people's lives pretty quickly,
significantly.
Right,
pretty significantly by having
from the physical
a
standpoint.
framework of how
Right.
to manage it.
Right,
Just 'cause, I mean, it doesn't.
The diagnosis again. You have
The
a
diagnosis doesn't
so
affect us, so we don't have to wait till you get oh, guess what? Great, you have EDS. You didn't have the classical type. Well, it didn't affect what I'm going to do with you. So it's just it's a patient population that I think is underserved. That I think PRI in general. So there's PRI professionals all over the country that I think have an idea of how they could help manage EDS, and it's I think very rewarding to kind of work with it. Do you recommend to avoid sports like jiu-jitsu for hypermobility to avoid vestibular problems? Yeah, so I think you take that both ways, Mac. Jiu-jitsu is kind of a challenging thing, right? So there's the trauma. I mean, you could get hurt
Put
doing
yourself
it.
in extreme motion.
You put yourself in extreme positions. However, the movement of doing a martial art like that, I think could be very helpful for somebody that really doesn't understand their own body. So people with EDS tend to have vestibular problems because they don't sense themselves very well. They don't really know where they are in space at all, and so they tend to be very potsy. We have that diagnosis, whether it's POTS or not. I don't care if they're in that pot or if they're not in that pot. But they don't know where they are. They don't have good vestibular awareness in general. They maybe have some eye problems because there's some corneal issues.
What's
They
that? Potsy?
potsy, yeah, potsy.
you're old.
Yeah.
Yes.
Patsy. But they do need some movement with some vestibular sense so they can actually train that. So jiu-jitsu might be actually a good activity, or tai chi, or some kind of
I was gonna say Tai Chi.
Movement-based
I
activity
would start
that's-
with something a little bit,
less combat
Yes.
oriented.
yeah, but.
It all depends on where the patient's
I was gonna
at.
say,
you
depends a
know,
little bit
yeah.
on what's your degree of instability.
Yeah.
Probably they're not going to want to spar and have somebody kick their knee out from underneath them. But to be able to grapple with somebody and figure out how to control your body
Right.
based on movement with somebody else, it's probably very effective, I would think, for certain populations. So if somebody wants to do it, I'm not going to say don't do it. It might be very, very valuable. I think, going back, I asked earlier, what would you offer anybody, just generally, somebody sitting in the stands at a baseball game? Well, make sure you're wearing a good pair of shoes, and make sure you're doing some kind of physical activity that's more strength or movement oriented rather than just yoga. Not that yoga's bad, yoga's good, but this population doesn't need yoga. Maybe they need
Sit on the mic.
jiu-jitsu, maybe they need tai chi, maybe they need something where they're actually
Challenging the muscles without
putting it in a position where they're going to be a problem. Like and I don't know the Mac how much jujitsu you're doing. If you're going extreme jujitsu, like MMA style, like hurt each other, but I know there's a lot of it that can be really valuable to patients in the right context. So, but I think some movement based strength activity for people. So kids who, hey, my kid stands there like their knees out all the time, or my kid walks around with their feet are pronated all the time, or I can tell when they're playing volleyball, their elbows are hyperextending. They're not necessarily having issues yet, but how would we encourage them to be healthy as they grow? Footwear, making sure they have good dental visits to make sure they're keeping their teeth good, because that teeth coming in might come in crowded. That's a sign. They might need earlier or more comprehensive ortho treatment. Making sure their visual system is good for that vestibular system you're talking about, the MAC, and just make sure they're active, right? So I think that's a big thing in a safe way. For those young kids that just that they're maybe a little bit discoordinated, they're maybe a little bit.
I think the big thing is just
right?
reassuring them that they can do some kind of activity, because a lot of these people
And
have a fear factor because they dislocate a joint or they do something and they have to go.
Obviously, we gotta be safe.
Medical
So
professionals or whatever.
that's
So I think the big thing
great
is just
thought. Be
doing
safe.
exercise, but be safe.
Yeah.
And it's okay to do exercise because
Yeah. So would you want a hypermobile patient playing football? And probably not. But you're gonna have kids that want to play football.
Yes.
And as a parent or as a person, you have to kind of weigh: is it worth it or is it not worth it? And pain kind of motivates you to not want to do it if you get to a point. But there's definitely activities that we'd recommend that you do. We don't want you to not be active. You just have to find the safe things to do. So, good question, Matt. I think that was valuable. Anything else did you think of anything just generally when you get somebody on your schedule that diagnoses EDS, and for the PTs that are watching, there is an EDS website where you can, if you feel like you have some good knowledge, if you do PRI work, you have knowledge and you can help anybody with hypermobility syndromes, whether it's EDS, whether it's whatever it is. There's people that are dying to find something that at least understands them. Yep. And some of the easiest marketing we do is we just put our name on this list and say we think we can offer something to people with hypermobility, and they're searching, they show up. So when you see somebody in your schedule, Dave, that says EDS, what's your mindset going in?
I think the biggest thing for me is, for the most part, you don't really treat the person different. We still go through our PRI evaluation. I think one of the biggest things is making sure we don't try to do too much too fast.
Yeah.
But our goals from a PRI standpoint are still the same. Yeah. What pattern are you presenting with? How do we get you neutral? How do we get you a little stronger in certain positions? How do we teach you to function? Just like I said, just not trying to push it too far too fast.
Having that confidence, it's great advice, because you're still a normal human.
Right.
You're still normal humans. They just happen to be a little loosier goosier, and just need somebody that has a compassionate understanding of what they're doing.
Right.
I think for me, like when I see it, I just know. It's like you get the tissue box ready, because just the fact I probably spend more time just chatting and listening to them, and our health history form is more detailed than most places, and we hear it all the time. Like, well, that's a weird question. Like, why do you care about that? But the amount of yeses they have. All right, tell me about this. You start to see different things. It's like, okay, well, this explains this. This explains this. So there's sometimes I don't even get to an exercise day one. Just them getting here was enough of a stressor. They're worried that you're gonna gaslight them. So just
Which happens, I think.
chatting with them and just yes, we can help, we can validate, and then you do some of the tests and you're like, well, this is this, and they're like, oh, and just talk about position changes. Like a lot of I don't even give an exercise. Let's just teach you how to sit in a chair. What can you do to help make that easier? Go home, work on it. And that alone, just the validation is huge for people, just to be heard.
So we think about the things you and Amy talked about. Is there anything that we should kind of touch on before before that video is coming out next week? Because you guys dive a little bit more into the weeds
Yeah,
with
we
some
dove
things.
in a little bit
So
more.
so if you've lasted this long, thank you for being here. There's more coming.
Ann did a great interview with Amy Morris, who lives out in Pennsylvania. So that'll be coming up in a week.
Next week, yeah.
So
Yeah.
watch that video. She'll give Elin a lot more information. This is
Yeah.
just like an introduction.
And
Yeah.
she, I think her big thing was get somebody on board that's part of your team, right?
Mhm.
And I think that's where hopefully we're wanting to get as part of that team. There's lots of people out there that we don't know.
Yeah, we're working on trying to find other providers as well. So figure out what we can do to help you. But Amy's great. So even if you watch the video, you're watching this, you have other questions, she is a great resource for all of us, and is willing to help and brainstorm and come up with different ideas. So anything that you guys see, let us know. I'm just diving into this. I'm just intrigued by it.
Yeah.
So we're all still learning and figuring things out.
So if you have a question, you can ask us. We can reach out to Amy. Or
Yep.
We're willing to redo. If we don't know the answers, none of us are too proud to say that we don't know. But I think we know enough people that we can research.
I think the big thing too is listen to your patients. If there's somebody, a healthcare provider that has helped them, use that as a resource for other patients, because there's some people they get, it might be the littlest thing that might have helped them, but I think that's a big thing because they always think they're being set up for failure. But if that one little thing helped them, use that for another patient, and maybe you can get your
start
numbers.
to get your network. So
All
Good
right.
deal. All right. Well,
all right.
Thanks for
watching. Yeah.
thanks for watching, everybody.
Thanks for the questions.
Thanks for the question. I'm glad it was up. If you have somebody that should watch it, feel free to share it, send it out, let people know. And I said, look forward to the video with Amy coming out next week. More stuff coming out with Amy McCracken. That one's coming out next week too. And then hopefully we'll see you back next month. We'll be doing another one for the first Wednesday of the month. We'll see y'all then. So thanks for coming. Appreciate y'all. Have a good night.